Hello, greetings. Depending on where you are, good morning, good afternoon, or as in the case of my co-presenter today, good evening. She is joining us from Germany today. So welcome to our public webinar, Application of LSVT LOUD to Neurological Conditions Beyond Parkinson's Disease. I am joined today, as I mentioned, all the way from Germany by Beth Peterson. I am Heather Hodges. I'll be starting us off today, and I'm greeting you from Denver, Colorado. We have listed for you our biographies if you wish to know more about us. I won't go into detail on those, but they are there in your handouts and on the screen for you to reference as you desire. The plan for the webinar, we'll talk about logistics first. This includes receiving the handouts. You should have been sent an email with the PowerPoint presentation earlier today for you to reference. So all of the slides that we'll be going through will be on the handout. We'll go through some presentation of content, and then after we are finished with the slideshow and AV, we will address your questions. When you are done with the webinar, a survey will automatically launch for you to take. We would love your feedback as well as any ideas on future public webinars that you would like to hear. Further logistics include our disclosures. So all of the LSVT LOUD faculty have both financial and non-financial relationships with LSVT Global. Non-financial relationships include a preference for LSVT LOUD as a treatment technique. And in regard to financial relationships, Beth Peterson is an employee of and also receives lecture honorarium and travel reimbursement from LSVT Global. And I receive lecture honorarium, consulting fees, and travel reimbursement from LSVT Global. And a few quick words for our professionals who are in the audience today. This is regarding information for self-reporting your continuing education activity. So the webinar is not ASHA or state registered for CEUs, but it absolutely can be used for self-reported CEU credit as a non-registered CEU activity. If you are a speech therapy professional and would like to self-report your activity, please email us at webinars@lsvtglobal.com so that you may request a certificate after completing the webinar, and that will include your name, date, and duration of the webinar for you to have on record should you self-report this webinar to ASHA for continuing maintenance hours. Licensing requirements for CEUs differs by state. So check with your state licensing board, and attendance for the full hour is required to earn a certificate. Our learning objectives for today, at the conclusion of this webinar, the participants will be able to discuss how a voice treatment based on principles of neuroplasticity has the potential to improve voice and speech in individuals with dysarthria, secondary to neurological diagnoses other than Parkinson's disease. The second learning objective is that you'll be able to explain the process for determining if a client with a diagnosis other than Parkinson's disease may be a good candidate for LSVT LOUD. And then finally, to discuss specific examples of the application of LSVT LOUD to other conditions beyond Parkinson's disease, we will be presenting specific case studies for you today. So we wanted to have a polling question today so we know who is joining us in the audience. So we will be launching this poll, and you'll see it come up on your screen. If you can please click the selection that best applies to you. So perhaps you are a person with Parkinson's, Maybe you are a family member, friend, or caregiver, a speech language pathologist, or an assistant, or a student, or perhaps you're a physical or occupational therapist, or assistant or student. And then other, if perhaps you're somebody who has a different diagnosis other than Parkinson's disease, that would be appropriate for you to click. So I'll give you a moment to select. You just click on the little white button next to the category that best represents you. All right. And so it looks like we have 10% of our audience are a person with Parkinson's, 3% are a family member, friend, or caregiver, 60% are speech language pathologists or SLPAs, and then 28% physical or occupational therapists or assistants or students. So that's great. It's wonderful to know who is in our audience today. Thank you for taking the time to do that. All right, so the presence of dysarthria has the potential to decrease speech intelligibility, and that can certainly interfere with functional communication and decrease quality of life. So we know that there is a need for efficacious treatment for those folks with dysarthria, and that we really need that. Today we will be presenting on some treatment data so you may maximize your treatment outcomes. Impacts of dysarthria will include decreased intelligibility, decreased naturalness of speech. It may also result in the individual encountering negative attitudes or discrimination. Ones that we frequently hear are patients reporting that unknown listeners may think that they are intoxicated, or perhaps that they're not as intelligent as they appear because of the negative impact of their dysarthria. And then we also see a diminished engagement in communication, which of course we don't want to have happen. We want people to stay communicating, not only for quality of life and to be a member of their community, but also from the plasticity principle of if you don't use it, you lose it. And we don't want people to lose function at an increased rate. We also know that treating dysarthria can be complex. Multiple areas, or perhaps all of the areas of the motor speech system, can be impacted. And so we want to be able to address that complexity with a treatment that has been shown to work and also is simple in nature for the patient to execute. So why do we consider LSVT LOUD for the treatment of dysarthria even beyond Parkinson's disease? First off, LSVT LOUD treatment will focus on restoring or improving function. It also promotes the use of residual function. And so that's where we can see that this can be applicable to those who've had an injury or a CVA or a TBI. It also establishes speech motor control across the system, which can be so important for those who have coordination issues, either from a congenital disorder such as cerebral palsy or Down syndrome, or somebody who has an acquired injury or a neurological condition that came upon later in life. So for these reasons, and because LSVT LOUD, the focus can hit on each of these goals and rationales for treatment, we see that it can apply to quite a number of circumstances and disorders. It is also because LSVT LOUD is an exercise-based treatment. Basic science evidence has established a great value of exercise in Parkinson's disease that classically had been only treated with drugs or surgery. It also has, science has also identified key principles of exercise that drive activity-dependent neuroplasticity. And so taking those upon the framework initially applied to Parkinson's disease, we see that it absolutely can translate to other disorders. And that science has demonstrated that exercise can improve brain functioning, which is super exciting when we consider the world of neuroplasticity in those who had perhaps an injury or, again, a disorder such as CP or Down syndrome. And for those with a progressive disease, exercise may be able to slow the symptom progression. So exercise is medicine. And that's also behind the rationale for why do we consider LSVT loud for other populations. The key concepts of LSVT loud are relevant for a variety of neurological disorders and a variety of dysarthria types. And so those concepts that really help to target principles of neuroplasticity include targeting vocal loudness. We're targeting increased amplitude, that the mode is intensive and high effort, and even in these populations outside of Parkinson's disease, we are still calibrating. And that's where we're addressing generalization of taking what patients learn in the treatment room, and they are able to generalize it, to take it out of the treatment room and apply these strategies that improve intelligibility, naturalness, etc., into everyday speaking conversational situations. So when we first look at the target and that we are targeting voice and specifically loudness, it's important to think of voice as a source. So when in therapy, your therapist, for those of you who perhaps have Parkinson's or are a family member that are joining us, when someone is difficult to understand, increasing volume helps that intelligibility. An example that we think of is listening to the television, where if I am not able to hear what the actors are saying, by turning up the volume, their intelligibility is now strong and intact. And so that's where voice can be a source. We also love what our colleague, Carol Bolick, poignantly said about voice, is that it can be a point of entry. In some other conditions, patients may need other types of therapy. They may need prolonged therapy, particularly our pediatric populations. However, because voice can organize multiple areas of the speech system, we see that it can be a really nice point of entry and make treatment more succinct and more simplified. And that is because voice, not only is it a source, it is also a trigger. So in LSVT's research, we have looked at the element of vocal loudness acting as a trigger that will enhance the effort and coordination across the motor speech system. We see that it increases respiratory support, that laryngeal, or from the vocal cords point of view, it helps with their movement, stability, coordination, that it can help with articulation as we move up the motor speech system into the mouth or oral cavity. And it may help with hypernasality. We see that targeting voice and increasing that loudness will help acoustically and in intelligibility studies where listeners can more easily understand the person talking. So we call it the spread of effects. And from a clinical point of view, this value is that it can optimize changes in speech intelligibility in a very simple and feasible way for patients. The focus for the patients is on loud. but they are engaging the whole motor speech system as a result of just thinking and talking loud. We also, in therapy, speech-language pathologists will shape and model normal loudness with healthy vocal quality. And this modeling can also impact improved deep breath, a more open mouth so that the voice and speech is more readily coming out to be heard. We're also modeling and shaping for improved articulation. That tackles the slurred speech or mumbled speech that may happen in dysarthria. Reducing the rate of speech for those who have fast rushes when they're talking. And the naturalness so that patients are not being perceived negatively when they're talking. And so that naturalness is addressed in therapy as well. So through the loudness being a source, loudness increases intelligibility. Loudness is also a trigger that coordinates the whole speaking system. And through patient observing the clinician's modeling and shaping, we see an improvement across the board. And then when we think about one of the principles of LSVT LOUD, it's the mode of therapy. Therapy is intensive and high effort, being 4 days a week for 4 weeks. This is really incorporating many of the key principles of neuroplasticity. Again, neuroplasticity is that idea of making brain changes or slowing the progression of a disease. And so with intensive high effort, there are multiple repetitions of each exercise. We are specifically targeting amplitude, bigness of movement, and that's through going louder. Complexity, that the therapy is never boring for the patient. It's never just a series of exercises that the patient is running themselves through, but instead for those patients, we are having them complete the tasks in various environments or with distractor tasks. We're never letting it be a boring or complacent activity because that does not enhance neuroplasticity. And that the exercises and the talking material, the conversations that the patient is having, that they're meaningful. And that's where we're getting into the saliency, is that it's driven by the patients, what they're interested in, what their goals for their speech are, that we really target that specifically as well. And this is important for both healthy and disordered motor speech systems. LSVT LOUD has been applied to patients who have voice changes simply from aging. Perhaps they don't have any other medical diagnoses causing for dysarthric speech, but instead they have what's known as presbyphonia, where due to aging, the voice can become softer, harder to hear. And so LSVT LOUD has been applied to that population, and it's important for us to keep these key principles of neuroplasticity in mind for both healthy and disordered systems. This is also key to affecting behavioral changes that last over time, that it's not patients receiving therapy for 4 weeks and improving for those 4 weeks, and after they graduate, they decline. But no, instead, because of the mode of treatment, we have really affected a behavioral change that will last, and that the data will show lasts at 6-month follow-up. Some data shows, 2 years or plus after therapy. And that this mode is absolutely applicable for children and adults. So it will talk about in our pediatric populations, cerebral palsy and Down syndrome, how the intensity was the same. It was still hour-long sessions focused on multiple repetitions, complexity, specificity, 4 days a week for 4 weeks, regardless of the age of the client. And then with that last principle of LSVT LOUD, we are addressing calibration. So in Parkinson's disease, we address calibration because there's a sensory mismatch, that patients are hearing themselves talk at a normal loudness when in fact their voice may be at a whisper, maybe quite quiet. And when we cue them for loudness, they think they're shouting. Well, in other neural conditions, there can also be sensory disorders present. So it may not be the same mismatch that we see in Parkinson's disease, but certainly sensory disorders from other neurological conditions are prevalent and need to be addressed in calibration as well, or else the gains made in treatment will not generalize. We also see in other neural conditions that vocal effort required for improved speech may be greater. We may be dealing more with a weakness. For example, someone with a unilateral weakness after a CVA. We may be having to address that type of calibration versus someone with Parkinson's disease who may not have such a unilateral weakness. There's also in Parkinson's disease subtle neuropsychological changes that are addressed in calibration, such as slowed thinking, slower learning, difficulty shifting cognitive sets, so from one task to another. But in the other neurological conditions, there are cognitive changes that need to be part of our calibration retraining. That may include language deficits, such as aphasia. Abstract reasoning may be difficult, and there may be delayed expressive or receptive language, such as with our pediatric populations. So calibration remains important as part of the treatment, whether we are dealing with Parkinson's disease or other neurological conditions. So how will a speech-language pathologist determine if LSVT LOUD is appropriate for their patient? So in the evaluation, when the patient first meets the speech pathologist, the therapist will be evaluating the clinical diagnosis and the rationale for focus on improving voice. They will use LSVT LOUD and their knowledge of it as a tool in their toolbox. They will look at the medical charts and consult with the medical team to see if there's any contraindications. Contraindications, the two most frequently is ALS and myasthenia gravis, where intense exercise is not appropriate for these populations, and thus LSVT LOUD would not be considered. And if, as the therapist is looking at the medical chart, thinking about the patient's diagnosis of dysarthria and what their neurological condition diagnosis is, if there's good clinical rationale based on the physiology of that disorder, they'll try what we call stimulability testing. The stimulability testing will be compared to baseline data. So the therapist will collect baseline data on the speech, loudness, intelligibility, etc. And then when they do stimulability testing, this simply refers to what happens when the therapist cues the patient to be louder, when they're able to achieve a louder voice. They will assess whether that increased loudness has a positive impact on the overall understandability for communication. So when evaluating that impact, see if the healthy or healthier vocal loudness you've achieved has an impact on voice quality. Does it improve articulatory precision? Perhaps it has an impact on prosody, which can absolutely improve naturalness of speech. And the same is true with rate of speech. You can be looking at all areas of this to determine, all areas of speech to determine if stimulability testing has a positive impact. And then from there, if in the evaluation and comparison to baseline data, the therapist and the patient are hearing some positive things happening, we say to go ahead and schedule the full 4 weeks of therapy, but after 4 consecutive initial treatment sessions, evaluate the impact. Can the client understand and approximate your instructions? This would be important, especially in the case of someone who has a receptive and expressive language delay or disorder. And is the patient showing signs of motivation and engagement? At the end of that week, look at their progress. If no progress is happening, or if they happen to have gotten worse, stop. This is not the treatment for them. But if at the end of the first week you're seeing good progress, continue with the therapy and that additional 3 weeks of 4 sessions each week. In treatment and through the process that the therapist will go through, document the treatment changes, how their phonation duration during the long is that being improved upon, loudness level, frequency. This is getting into those pitch exercises. What changes are happening in frequency of hertz and their highs and lows. And also important, the amount of cueing that the patient needs from the therapist. Monitor also the perception that you are having of vocal quality. Is it improving in your patient over time? Check in with the family too for their perception of their communication participation. If the patient is communicating more, they have more confidence, then we know they're starting to use their voice again. So instead of, if you don't use it, you lose it, now we see, gosh, they're using it again, and if you use it, you can improve it. And of course, checking in on your client's perception of their voice, speech, and communication participation from their point of view as well. All right, and so now that we have provided a framework on why LSVT can be a consideration in your clinical toolbox for other neurological conditions beyond Parkinson's, and how to assess if a patient is appropriate through stimulability testing, assessing the first week of therapy, and continually monitoring progression and treatment changes. Now we want to share with you some case studies. So I'm going to hand it over to Beth, who's going to share various case studies on some of the other neurological conditions.
Okay, thank you, Heather, for a great introduction and rationale for LSVT LOUD, and then also, again, how to determine if someone may be a good candidate. So as she mentioned, I'm going to go ahead and go through some case studies, and so that you can hear differences pre to post in some of these other populations. We'll also have one video in here. So on these next, kind of the second half of the slideshow, we'll go through these cases and then again also present you with some examples so you can hear the differences. So first, I'd just like to show you some of the populations that have been studied and that we have research data on. So Parkinson plus, or more commonly now, atypical Parkinsonism, post-surgery or fetal cell, stroke or CVA, multiple sclerosis, ataxia, cerebral palsy, Down syndrome, deep brain stimulation, and aging. So these are some other areas where LSVT LOUD has been applied. These you can see at the top are either single subject, case study, or small group design. So we don't have the wealth of data for these other populations like we do for Parkinson's, where we have the large randomized control trials. So that's why it's important to, if you are thinking about working either as a patient, if you think this may apply to you, or as a speech therapist and you might consider a different population. That's why those steps during the evaluation for stimulability testing are so important, to see if there is something with LSVT LOUD that can help with the communication in one of these other individuals that doesn't have Parkinson's. So we'll go ahead and look at some of the data here. So this shows you across a few different disorders other than Parkinson's, from pre-treatment, those are the bars in purple, to post-treatment, which are the bars in yellow, and then all the way out to 6 months after treatment, which are the kind of peach pink colored bars. And so we see for brainstem encephalopathy, a stroke, multiple sclerosis, and we compare that to the Parkinson's group on the far right. And you can see across all the different populations that we had some good changes. We're looking at decibels of sound pressure level, which is the acoustic correlate for loudness. So we're looking at loudness from pre to post to 6 months. And so we see across these other populations very similar trends to what we see with the Parkinson's group. So we're seeing that good improvement post-treatment, and that those gains were also maintained out to 6 months. So at the top graph here, we see it's reading a rainbow passage or a standardized reading passage, and the bottom is conversation. So more spontaneous speech. And that's really the end goal of treatment, is that we're able to get that conversation level speech to improve. And so we're seeing that improve across these other populations as well as Parkinson's. So it's very exciting data to see maybe LSVT LOUD can be applied to other populations successfully. I'm going to go through some of these different populations here on the next slides. The one I'll start with is I'm looking at a gentleman, we'll do a case study here, who suffered a stroke, and some information on stroke or CVA. It's a leading cause of disability in the US, and this dysarthria can interfere with communication following a stroke. So dysarthria can occur following stroke, and it comprised 54% of acquired communication disorders. The case study that we'll look at, so this is a gentleman at the time of this case study, he was 37 years old. He had a left hemisphere hemorrhagic stroke, also resulted in Broca's aphasia, and the cause of trauma was an artery was punctured. And it was 3 years since that had happened. And we'll go ahead and listen to his sample. So we'll hear him pre and post LSVT LOUD.
Nineteenth.
Correct. What problems do you have talking?
Loud?
Mm-hmm.
No.
Mm-hmm.
I hear. I don't know. Here.
Mm-hmm. Okay. Do this for me. Take a deep breath and say ah for as long as you can. Okay. Count for me from 1 to 25.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
Great.
Okay, so that
Do you feel that people have a hard time understanding you often?
Yes.
Okay.
And now we'll hear his post-treatment. That was the pre-treatment.
Date.
24th of May.
Okay, do this for me. Take a deep breath and say ah for as long as you can. Okay, now count from 1 to 25.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
You have had 16 sessions of speech therapy with Cynthia.
Yes.
Is it true? It is indeed. Have you noticed any changes in your
Yes.
speech? Okay, tell me about that.
Cool. I get no, whispering.
Do you think it's easier for people to understand you?
Yes.
Has anybody commented that?
Yes. A lot of people.
Do you feel like your voice is reduced in loudness
Now,
now?
no.
Okay, did you feel it was before you?
Yes.
Okay, so I hope you could hear some differences there. So you could hear some improvements in rate and loudness. And I think for him, what really sticks out is that improvement in articulation. And you can also hear through the video his confidence. I know we can't see him, but he really was exuding that confidence post-treatment because of those improvements. And as he's saying that other people have commented, he feels that he's easier to understand now. So some exciting data from him. What's also exciting about individuals with stroke is we know they're only getting better, so they're on the road to recovering. So it's exciting to do this treatment and know that they're only going to improve from there. So some lessons with stroke. The shaping of good quality loudness can be challenging, so it can take more time to shape the voice that you want into that good quality loudness versus with Parkinson's, where the shaping might not take quite as long. The change may occur more slowly than in people with Parkinson's. So again, if you're used to treating people with Parkinson's, that you may notice some differences with stroke in terms of how fast, or I should say, not quite as fast of improvements for individuals post-stroke. Considerations if aphasia is present. So likely these individuals would also need some type of language treatment. So LSVT LOUD is not going to be the only treatment they would need. They would need some type of treatment focused on language amongst potentially other focuses, but it's exciting to get the voice through LSVT LOUD, and we see those improvements spread across into articulation, specifically with this gentleman. And so just knowing expectations for the outcomes. So again, if you're used to treating Parkinson's, the expectations may not be the same for Parkinson's, so just having that in mind when treating these other individuals. We'll now look at cerebral palsy, and we'll look at a few, we'll focus here on kids, but you can also use the treatment for adults with cerebral palsy, and we actually just had one of our other faculty members who has done it for a couple recently, a couple individuals with cerebral palsy, adults, with some good outcomes there too. And this slideshow, we have some outcomes for the kids that have been treated. So with cerebral palsy, dysarthria is common, and it's typically characterized by hypernasality, breathy voice quality, a reduction in loudness, and rate abnormalities. So as Heather mentioned, talking about the spread of effects, so these are all things that potentially through LSVT LOUD could be improved. We'll go ahead and listen to some audio samples of 5 kids. These were in a small group design study with Cynthia Fox and Carol Bullock that have been published. And so we'll hear these samples. These were all kids between 5 and 7 years of age at the time of the study. And you can see on the slides, and I'll reference which one I'm playing each time, but we'll look at their pre to post. And then the last one you'll see is someone who did not receive treatment. And so that you can hear pre to post, there were no just spontaneous changes. So this helps us see, was there really a change because of treatment, or would change just have occurred naturally? And so we have a no treatment group so that we can see over time, the same amount of time that others received treatment, that individuals who didn't receive treatment, that we're not seeing a change. So we'll go ahead and listen to these. I'll start with number 1. So this is a little boy, 7 years, 10 months. And the first part of the sample, it will be pre, the second part will be post.
Pair 8, sample A.
Bye, Bobby, puppy. Bye, Bobby, bye, Bobby, puppy.
Sample B.
Bye, Bobby, puppy. Bye, Bobby, puppy. Bye, Bobby, puppy.
Okay, so he's saying bye, Bobby, a puppy. The next one is number 2. So this was a little girl, 5 years, 10 months.
Pair 6, sample A.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Sample B.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
All right, so some nice improvement there. We'll look at number 3. This was a little boy, 6 years, 1 month.
Pair 9, sample A.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Sample B.
The blue spot is on the key.
Ready?
The blue spot is on the key. The blue spot is on the key.
Right, and number 4, another little boy, 7 years, 7 months.
Sample B.
Poopy, poopy.
Pair 7, sample A.
Puppy, puppy, puppy.
All right, so his utterance length was only at the 1-word level, so that was him saying puppy instead of the whole phrase, "Buy Bobby a puppy." But also with that one, you could still hear differences with even just the 1-word utterance and being able to understand him. So this last one is, again, the little girl who didn't receive treatment. So pre to post, you shouldn't be able to hear much of a difference, if any. But we'll play hers here. Oops. Hopefully I can get this. Oh, man. It's trying to play the other one. Let's see if I can play it another way here. Sorry about this. Oh. If I can't get it, I'll just move on. I didn't realize they were overlapping so much. It's taking me to the other box. So I'll give one more try. And see if we can go here. Okay, sorry, I don't want to keep trying to play it and then going back and forth on the screen. But for her, so she was untreated and there's not a difference from her pre to post. Whenever we do an untreated group in one of the treatment studies, that group always receives treatment at the end of the study. So this is a video example of her receiving treatment. This is in her 4th week of treatment. And so I think it's nice to be able to see what it might look like with kids. As Heather mentioned, the treatment is the same. We do the same intensity, the same length of time. So it's 4 days a week for 4 weeks. The activities may differ just in terms of we bring them to the level of the child, but they're doing the same exercises in every session. So we'll go ahead and look at her in week 4. Actually, I'm going to play it just a different way that might show up a little better for you.
Oh, perfect, Miss Katie. So what we're gonna do is you're gonna give me a nice big ah. Ah. Whoa! What did you get?
I got 953.
Good talking. Okay, up big and tall. Whoa, that was a big one. Good job. I bet you could take a bigger breath though. What do you think? Keep going. Big and tall, big and tall, big and... Wow!
1345.
That's our longest one today, isn't it?
Yes.
Let's tape record them so we can hear how they sound. Okay, ready?
Hello, this is Katie. Good morning. Stop it. Okay. Yes, please.
Are you ready with your big, beautiful voice?
Yes.
Okay.
Hello, this is Katie.
Perfect.
Good morning. Stop it. Okay. Yes, please.
Don't forget to breathe.
Mom, Dad, come in here. Can I wake up? Stacy, thank you. Excuse me.
Okay, what if they didn't hear?
Excuse me.
Good. All right.
Okay, so hopefully you're able to see how treatment, again, with kiddos is going to be the same exercises that we do with adults. We might incorporate games or, again, make it more child-friendly depending on their reading level. We might have them, you know, describe pictures or something where if they're not able to read, we'd have to be more creative with the material. But the same exercises, 60 minutes every session. So pretty neat to see it with a kid as well. So Down syndrome is another population that LSVT LOUD has been applied to. So with Down syndrome, communication disorders are common and also frequently include dysarthria. Therapy typically with Down syndrome focuses on cognitive linguistic deficits. And speech treatment in Down syndrome has received little attention, even though those speech deficits may have a negative impact on quality of life and social participation. So it is important to get out there and really be trying to research what can work with Down syndrome to help these kiddos have a improved quality of life. So some lessons with cerebral palsy and Down syndrome. So shaping good quality loudness can be, again, more challenging than we might see with Parkinson's. Change may also occur more slowly than in individuals with Parkinson's, and also with kids considering, you know, considerations if language and cognitive impairment is present. And then the timing of treatment. So with these kids, again, LSVT LOUD is not going to be the only treatment that they need, but as Carol Bullock mentioned on one of the slides that Heather presented, voice, so focusing on voice through LSVT LOUD may be a good point of entry to make improvements into other areas of the system. So you may have heard in the audio samples pre to post, so you may have heard the loudness improve, but you may have also noticed breath support was better, the articulation was better. So some of those other areas that maybe you think, oh, why would I work on loudness if I'm more focused on, you know, respiratory concerns or articulation, but you can see that thread of effects from being louder across those kiddos and see those improvements from pre to post treatment. So the next population I'll talk about is multiple sclerosis. And so we can see on the slide here some information. About 40 to 50% of individuals with MS suffer from dysarthria. And most commonly, it's spastic ataxic dysarthria. Some of the prominent features include impaired loudness, breathy or hoarse voice quality, vocal instability, and imprecise articulation. This is another population where we need more treatment research to see what would be the best or a good treatment for individuals with MS. We'll look at a case study here that has been published as well. So this is a 46-year-old female, or she was 46 years old at the time of the study. She had progressive MS with superimposed exacerbations. This was 12 years since the initial diagnosis. She was in a motorized cart, and her cognition was not, within, deemed to be within normal limits. So some of the pre-treatment voice and speech signs. She had a weak voice, intermittent breathy voice. There was observed deterioration of vocal loudness with extended use. So over time, her vocal loudness diminished. On the ENT exam, there were no laryngeal anomalies. She had good speech production and no lesions. So we'll listen to her pre-post audio sample as well.
When did you first notice anything in your speech or your voice?
I was hospitalized 2 years ago in January, and I was in a rehab center for a month, and I got passes to go out to the chorus meetings that we have, and I was very, very weak. in singing. Had no strength at all, and it was mostly abdominal.
So you noticed that it was difficult for you to.
Oh, I could produce very little sound.
Do this for me if you would. Take a deep breath and say ah for as long as you can. Would you say MS has caused you to talk less?
Probably, especially when I'm fatigued. I can get to the point that I can't even talk above a whisper.
Do this for me if you would. Take a deep breath and say ah for as long as you can. Whoa! How has your speech or voice changed as a result of speech therapy?
Oh, before I would never have even considered talking in front of a group, especially without a microphone. I would have most likely given my announcement to the president and have had her read it for me. I have much more confidence. I feel like when I am telling somebody, say somebody that I'm dealing with business-wise, when I have to talk with them, I feel like because my voice is stronger, that I have more clout. I feel much, much more confident and happier.
Tell me about the relationship between your voice and fatigue.
Okay, when I first started therapy, doing the things that Cynthia asked me to do, I would get a very tired, very fatigued feeling in the diaphragm area, and it was hard for me to go on, and I wanted to say, look, that's enough, Cynthia, leave me alone. But as the time went on, that feeling went away, probably in about.
All right, so with her, hopefully you could hear the differences pre to post. Again, she talks about her confidence, that loudness improves, overall clarity of her speech. So some nice changes with her. So some considerations, we'll look at her post-treatment voice and speech changes first, and then we'll get into some considerations with MS. So we heard that increased loudness. So she also had decreased fatigue. So it was, and that's what she was talking about. She was able to maintain that loudness more easily. She also said there was improved singing strength. Her confidence improved, and on the ENT exam, it did show marked improvement in both the strength of the voice and the adductor tone. So some considerations with MS, clinicians would want to treat with LSVT LOUD during periods of remission, not during relapse. The timing of treatment matters, and this is on a case-by-case basis. So we've also had individuals with MS, another case say that was written up, that did not have this great of an outcome as we see with this patient. It might have been because it was so much further on in the course of the disease, whereas this one was treatment was tried earlier on, so there was more capacity to improve. So that timing of treatment can be, should be considered with MS in terms of what expected outcomes might be. But this would be a population where it certainly would warrant doing stimulability testing to see if they might be a good candidate. So next I'll talk briefly about deep brain stimulation. And so some speech characteristics that we're research is showing post DBS is that neurosurgical intervention does not consistently or effectively improve speech in Parkinson's. So while some individual components of speech may improve, the loudness of sustained phonation, the oral force or control of the tongue, or overall speech intelligibility is not improved. So even though we may see some limb improvements following deep brain stimulation, we're not seeing the same improvements for voice and speech and communication. So speech problems, dysarthria, are reported after deep brain stimulation in about 5% to 61% of cases. So from the patient perspective, here's some of the research, what the research is showing that patients are noticing. Significant differences in the severity of their perceived speech disturbance compared to a group that did not receive DBS. More severe symptoms are reported. They have more symptom interference with social interaction and their daily experiences, which relate to functional, physical, or emotional issues of the voice disorder. So it's definitely having an impact on their overall quality of life. Low volume was the most common speech symptom, and DBS also had the greatest adverse impact on slurred speech. So we're seeing some of those more severe voice and speech symptoms post-DBS. This was a study that was done by Jennifer Spielman, and it was looking at 3 individuals post-DBS who received LSVT LOUD. And so we're looking at the vocal loudness level of all these participants. So purple, the light purple is pre, the darker purple is post, and the yellow is follow-up at 6 months. And so again, we see some improvements pre to post, and for the 2 that were able to come in at 6 months, we're seeing some maintenance out to the 6-month mark as well. So some promising findings for LSVT LOUD post DBS. And so I'll play this is a real short audio sample of someone, you'll hear her first post DBS and then post before she receives treatment, and then you'll hear her after receiving LSVT LOUD.
I knew the chance of slurred speech was great.
Okay.
But I didn't realize that that's what it was going to sound like.
Okay. So really be thinking loud and fast when you're ready.
Oh, my little kitten, how are you? Are you hungry? Hello.
What do you think?
I think that that's the best I've heard my voice in years.
Okay, sorry, that clip was a little quick, so I didn't intervene to tell you the post, but after the clinician had said now loud and fast, and that's when that was post treatment. So you could hear the difference in that short clip from pre to post. And so you heard the cue of loud and fast, and so rate was a target for treatment. So even though the focus of treatment was all on loudness, this clinician did add that cue of loud and fast toward the end of treatment, and you could hear the improvement in her rate as well as the improvement in loudness and just that overall clarity of speech. So some feedback from the treating clinicians that worked with individuals with DBS. They said that the participants had a greater difficulty producing the target phonations and the loud speech during exercises. There was more persistent hoarse voice quality, more severe slurring, impaired tongue control. There was more difficulty with carryover of that improved voice into conversational speech. One possible explanation for this can be that the stimulator settings for the DBS were high for these participants, which has been shown to negatively affect speech intelligibility. So when working with individuals with DBS, it is important to optimize those stimulator settings for speech. And so to do that, you would work on a team with the neurologist and neurosurgeon to adjust the stimulation and find the best contact and voltage settings that the patient is also happy with in terms of speech, and then also in terms of their movement. For behavioral speech treatment, so LSVT LOUD can be done. You can try out the stimulability testing for that. You may need to do more treatment, so it may be beyond the 4 weeks, maybe another week or 2 to get these individuals to their best outcomes. You may have to follow up more often, so instead of 6 months like we typically recommend for Parkinson's, this might be 3 months. You may also consider pre-treating with LSVT LOUD before DBS and then seeing if that has any type of improvement on some of those other communication symptoms that we saw post DBS, and then maybe you'll go back in again and do LSVT LOUD post DBS as well. And in terms of their speech impairments from stimulation, you might try trials of behavioral speech treatment, and then some individuals may still need augmentative communication devices to make sure that they can actively participate in the conversation. All right, so I'll go over one more population and then we'll wrap it up because I know we're at our hour here. So with atypical Parkinsonisms, this comprises about 12% of Parkinsonian disorders, and typically speech and voice deficits are more severe and deteriorate faster than with idiopathic Parkinson's. But we say don't discount the potential based on initial impressions. So you may have patients who have more of a cognitive involvement, or they may seem more apathetic, or may have a more challenging physical condition. But we say, you know, these are still individuals that would be worth it to try STIMULABILITY testing to see if LSVT LOUD possibly could help them. The long-term goals may be less than with idiopathic Parkinson's. So maybe instead of getting to that conversation level, you're at the phrase and sentence level. They may need more cued loudness at the end of treatment. And they may also need more frequent follow-up. So maybe 2 months post-treatment instead of, again, that 6-month recommendation that we typically give for Parkinson's. So I'm going to skip over this last case report, but I would like to just let you know that it is on your handout if you want more information. This was a young adult with autism that one of our other colleagues worked with. And there's actually a write-up in the Huffington Post on it that you can see the link on this slide if you do want to read the story that was written up about it. So just general considerations, LSVT LOUD is not for everyone, but it can be another tool in the toolbox if other treatments that you're trying just aren't improving the patient to the degree that you think they can improve. So the STIMULABILITY testing results, clinical judgment, and client and family discussions are going to guide the decision on whether or not to progress with treatment. There are some diagnoses that are just absolutely contraindicated because it would not be helpful to the patient to have this effortful intensive treatment. So myasthenia gravis, ALS, and multiple sclerosis in periods of exacerbation. So we're at our hour mark. If you do need to sign off, I don't want to hold you up, so you can sign off and you'll still get credit for attending for the full hour. If you want to stay on, Heather and I are happy to stay on for 5 or 10 minutes and address any questions that come through. But again, if you need to sign off, feel free to sign off, and you can email us webinars@lsvtglobal.com to request a certificate, and you can get a certificate for participating for the hour. And when you X out of your screen, a survey should pop up, so you don't need to wait for the webinar to officially end if you'd like to take that survey. So if you do have a question, you can type a question in the question box on your webinar control panel. You can also raise your hand by clicking on the hand icon. We'll see that you have your hand raised, and I'll call out your first and last name and let you know that we're unmuting your microphone. And then you can always email us later if you think of questions. So info@lsvtglobal.com. Okay, so the first question that came up, so where to email for the certificate. So it's webinars@lsvtglobal.com. And at the end of this webinar, you'll receive an email. It's an automated email. I think it gets sent about an hour after the webinar, and it will also have that information, and it will have the email address in there in case you weren't able to get it during the presentation here. Okay, and Heather, if you want to take the next question. So do you have to keep doing LSVT for the rest of your life?
Good question. So with patients, regardless of their diagnosis underlying their speech and voice disorder, whether it be Parkinson's, cerebral palsy, multiple sclerosis, etc., we do see that many patients benefit from what we call tune-up sessions. So when a patient has their 4 weeks of therapy, one of the recommendations their therapist will make is that they continue with a home exercise program. The home exercise program takes maybe 10 or 15 minutes a day for the patient to complete. And that's because, just like any other exercise, if we stop exercising, we'll lose some of our gains. We'll lose some of our function, some of our strength. A runner who stops running, they will have repercussions from that. And so certainly continuing lifelong homework is indicated for anybody and everybody who completes LSVT LOUD. And then depending on the underlying diagnosis, we encourage that the patient and speech pathologist stay in touch, whether that means checking in every 2 to 3 months if it's something like multisystem atrophy or one of those unique Parkinsonisms, or perhaps a little longer of a check-in period, like every 6 months or once a year, if it's something like CVA, stroke, or idiopathic Parkinson disease. For some conditions like a stroke or a traumatic brain injury, we see in some cases that patients who continue to practice their homework afterwards may continue to get better because their insult was not from a neurological or progressive disorder. When they have a disorder underlying that is progressive, such as Parkinson's disease, we would say, yes, you may need tune-up sessions. Those tune-up sessions often do not involve 4 additional weeks of 4 times a week, but may just be every 6 months or a year. I've had some patients who go 7 to 10 years before needing tune-up sessions, and they just need like less than a handful of sessions to get back on, recalibrate. Perhaps they got off of their homework plan. So the short answer is yes, to some degree, LSVT LOUD is lifelong, even if it's just maintaining 10 minutes of homework practice every day after you discharge from treatment, and then up to the potential for tune-up sessions occurring as needed by the patient. So, and that can be determined with the speech pathologist who gets to know your voice and your needs intimately in the 4 weeks you're with them. They can help determine that check-in schedule and whether or not you need tune-up sessions at any given interval.
Thank you, Heather. So great question and great response there. We had a question come in that the video of the little girl doing treatment, there was no audio. So I think that happens if you're listening by phone or a certain connection. So I can go ahead and play that video again a different way. I just want to, and I think that addresses all the other questions in the audience. So if you do have a question, I'm going to go ahead and play this video, and so we can end on this. So that you can see treatment. So this is the little girl with cerebral palsy who didn't receive treatment during the study, but she received treatment after the study. So I'm going to play that, but just letting everyone know. So if you did see the video and you don't want to watch it again, you can sign off because we'll wrap up with this video. If you do think of questions later, again, though, feel free to email us. It's info@lsvtglobal.com, and you can see that on your slide there. So let me go ahead and pull up this video. Make sure you can see it. Okay. So when we play, there's a couple ways to play the videos in the webinars. The way I'm going to play it now, there may be a slight delay between the audio and video, just the way that the technology works. But this way, you should at least be able to hear it. So let me go ahead and play it for you.
Oh, perfect, Miss Katie. So what we're gonna do is you're gonna give me a nice big ah, ah. Whoa! What did you get?
I got 953.
Good talking. Okay, up big and tall. Whoa, that was a big one. Good job. I bet you could take a bigger breath though. What do you think? our longest one today, isn't it?
Yes.
Let's tape record them so we can hear how they sound. Okay, ready?
Hello, this is Katie. Good morning. Stop it. Okay. Yes, please. Mom, Dad, come in here. Can I wake up? Stacy, thank you. Excuse me.
I think the big voice fairy came to your house last night and gave you your big voice. Are you ready with your big, beautiful voice?
Yes.
Okay.
Hello, this is Katie.
Perfect.
Good morning. Stop it. Okay. Yes, please.
Don't forget to breathe.
Mom, Dad, come in here. Can I wake up? Stacy, thank you. Excuse me.
Okay, what if they didn't hear?
Excuse me.
Good. All right.
Okay, so hopefully if you weren't able to see that before, you're able to see it now. Okay, so there were a few other questions that came in, so we can certainly address those. Okay, so this question, so what exactly is done in the therapy sessions for LSVT? Is it related to only voice? So yeah, that's a great question. We didn't go into too much depth into that in this webinar. We do have other public webinars that go into more depth than that, and so you can find those on, I'll certainly go over that, but I just want to let you know we do have webinars that go a lot into depth of what the treatment looks like. So if you do want to have more visuals for it and some more examples, if you go to our website and you'll see in the email you received too, so blog.lsvtglobal.com, and you click on on-demand webinars, you'll see lots of webinars that we've recorded in the past, and you'll see some that I think they're, if you type in like introduction to LSVT, then you'll be able to really see a whole webinar on what the treatment looks like. So I'm happy to give a brief overview here as well so that you know more what treatment looks like. So LSVT LOUD, as Heather mentioned, it has a focus on voice. So we're targeting vocal loudness and really just vocal loudness only. So the patient is only thinking about being loud. The clinician is shaping the voice and thinking about other things like, can I improve breath support, articulation, other areas of communication, but all through the focus of voice. So the patient is only focused on having a louder voice. And the treatment is 4 days a week for 4 weeks, and each session is 60 minutes, so 1 hour. And the sessions are one-on-one with the speech therapist. And so the treatment every day will include what we call the daily exercises. So we start with a long, loud ah, and you heard that in some of the examples. So ah, and we do multiple repetitions of that. And then we have repetitions of a high ah and a low ah. So a high would sound something like ah, and a low ah. So my voice, I'm keeping the loudness up, but I'm going high and I'm going low. And then we have what are called functional phrases. And so you could see Katie doing those in the video. And those are 10 phrases that a client selects that are said every single day, and that we work on that loud voice in those phrases. So they're phrases, again, that are said every day. So this is an exercise that really becomes overlearned because you're doing it in treatment. And then when the client goes home, they're also doing it in their daily living. And so we're hooking into their daily living to really get that loud voice into their everyday environment. On the second half of the treatment, we do what's called a speech hierarchy. So now we're taking that loud voice and putting it into more speaking specific exercises. So in week 1 of treatment, we work at the word and phrase level. So we're trying to bring that voice into words and short phrases. So focusing on the loud voice there. And week 2, we're moving into a sentence level. So anywhere from 1 to 3 sentences. The third week, we work at kind of a paragraph level reading, so that continuous reading. And then when we get into the 4th week, we're working at conversational speech. So we're doing exercises where we're trying to get more conversation so that the end result, again, is to have that loud voice carry over into conversational speech. So we progress from week to week in terms of the length of the utterances and the complexity of the tasks. And so by the end, we have this loud voice that's walking out the door using that loud voice in everyday living. So in addition to the sessions, the daily sessions with the therapist, there's also daily homework assignments and daily carryover assignments, which is carryover assignments are exercises that a therapist would give specifically for a client to practice something that they're doing that they're already doing in their day, but they're going to use their loud voice. So an example might be you're going to go to Starbucks and order your drink. When you order the drink, I want you to say, I'd like a tall decaf vanilla latte in your loud voice. So that's a carryover exercise. So those are done, homework and carryover exercises are done all 30 days of the month. So at the end of treatment, as Heather mentioned, then we follow up with patients depending on the severity of the disease, how well the patient did by the end of treatment. We follow up, anywhere from 2 to 6 months to see how a patient is doing. And we may bring them back in for what we call tune-up sessions if we need to bring them back in and recalibrate them. But that's kind of a quick-ish overview of what LSVT Loud looks like. And again, if you want to get a more in-depth overview of the exercises and have more visuals and have more examples, I would encourage you to look at some of the webinars that introduce you to the treatment, LSVT Loud for voice, and then there's also a treatment LSVT Big for physical and occupational therapists. Heather, I don't know if there's anything you want to add into that overview of what it looks like.
No, that was a really nice job of an overview, as nice and succinct and thorough. Great job.
Okay, well, great. The last question that came through kind of related to that. So how is it different from normal voice therapy? So some of the exercises are certainly done in voice therapy, but that intensive mode of delivery is not typical in traditional voice therapy. So some of those neuroplasticity principles that Heather was mentioning, the repetition, the saliency, so all the activities are really tailored to be individualized to the patient. So we don't want clients just reading from a list of phrases or, reading things that are of no interest to them. So we really make sure that the materials in treatment are salient to the patient, because we know that can have an impact on the outcomes of treatment and how well a patient does during treatment. So again, the mode of delivery is probably the biggest difference, is that intensive mode of delivery 4 days a week for 4 weeks, 1 hour each session, and then following with those neuroplasticity principles, repetition, saliency, that intensity. So those are some of the big ones. Okay, so I think that wraps it up. We thank you all for joining us today, and thank you, Heather, for being an excellent presenter. We hope that you can join us for another webinar in the future and that you all enjoy the rest of your day.
Thank you so much. It's been a pleasure.